Thank you all for joining. Like Sue mentioned, today we're going to be talking about IBS, or irritable bowel syndrome, in children. So let's get started. And so I have nothing to disclose. And first off, right off the bat, I just wanted to let everyone know that April is actually IBS Awareness Month. So I find it's only fitting that that today's talk is on IBS. So there you go. So we're going to go over, some of the goals and objectives of what we're going to talk about here. So basically, by the end of the talk, my hope is that you'll be able to understand how IBS is diagnosed, what testing, if any, is needed in making the diagnosis, when should you be concerned about something more serious, and to be familiar with some of the treatment options for IBS. And so first we're going to talk about, what is IBS, and then the different subtypes. There's a few different types that we'll talk about. And then how do we make the diagnosis and what causes IBS? Because it's not super straightforward, and everyone's IBS is a little bit different. We'll talk about alarm symptoms, so when to be worried and when not to be worried. And then we'll spend a little bit more time on treatment. So what is IBS? IBS is very common. We see, it's very common in the general population, and we see it a lot in our clinic. But the textbook definition is having recurrent belly aches for more than 1 day a week for the last 3 months, and usually associated with at least two of the following. So defecation or pooping, change in stool frequency, how often you're going, and or change of stool consistency. Is it hard? Is it loose? How does it generally look, essentially? And basically the criteria has to be fulfilled for the last 3 months, with symptoms starting at least 6 months or more before. And these are criteria. This is a textbook, but not every single patient with IBS fits this box. So there's some wiggle room here. But also, IBS is not the same as IBD, which is inflammatory bowel disease, and autoimmune disorder, which is sometimes we test for, but they sometimes may be confused because they're both three-letter acronyms. So IBS is not the same as IBD. And so, talking about the subtypes of IBS, there's two real main ones: abdominal pain associated with constipation, or IBS-C. Abdominal pain associated with diarrhea, or IBS-D. And then you can have a mix. So you can have diarrhea and constipation associated with belly pain, and that's IBS-M. And then we have some patients who don't have constipation or diarrhea. They're pooping fine. And so that's abdominal pain not otherwise specified, IBS-U. All right. So how do we make the diagnosis? The biggest, the two main elements of the diagnosis are history, so getting a good history from the family, caretaker, guardian, when did symptoms start, what's worsening the symptoms, what makes them better, any medicines that have been tried or prescribed, things like that. And recent travel, all that's very important. Physical exams also extremely important. And so making sure we listen to heart and lungs, and is there any significant tenderness on the belly exam, or other things like that. And we can make the diagnosis with little to no testing, since it is a clinical diagnosis. But sometimes we need to get testing if there's concern for other diagnoses that we want to rule out, whether it is inflammatory bowel disease or IBD or celiac disease, for example. We may check some blood work. So this is some of the blood work we might check. It's not super important, but ruling out celiac disease. Sometimes a thyroid disease can present with belly pain, and then also looking at anemia and general markers of inflammation. Sometimes we'll get stool studies. to look for acute infection. So like a gastroenteritis or stomach bug can sometimes present kind of similar to IBS. And then also looking for chronic inflammation. Stool test called a fecal calprotect. Again, the name's not super important, but basically that's the general categories of testing that we'll get. And sometimes we'll get abdominal imaging. Could be X-rays, could be ultrasounds. We rarely get, CT scans, but depending on the history and physical exam, we may. And excuse me. And then in some patients, we'll end up having to do an endoscopy or colonoscopy. And again, that could be to rule out inflammatory bowel disease or celiac disease or certain bacterial infections of the stomach or severe reflux or a whole host of diagnoses that we want to be able to rule out before committing to the diagnosis of IBS. So that can sometimes help narrow the diagnosis and treatment options. And so moving on to the causes of IBS. So what causes it? I mean, it's variable. It depends, each patient has, different basically their triggers are different. And so it's very individualized. So there's lots of data on altered GI motility. So what is GI motility? So basically it's how your intestines are moving food and digested food and stool through your GI tract. How quickly that transit time is. Is it too slow? Is it too fast? That can contribute. Something called visceral hyperalgesia. So it's a fancy word, but visceral hyperalgesia or hypersensitivity is basically this increased sensitivity to pain in the internal organs of the body, like stomach, pancreas, intestines. And the visceral hyperalgesia or hypersensitivity can be caused by inflammation. So you get a recent bug or something like that, or infection, or even stress, which can then cause changes in what we call intestinal permeability. And then this, in turn, can lead to additional inflammation and release of certain chemical messengers, like serotonin and histamine and other hormones and things like that. And this can go on to activate pain receptors, which can lead to acute symptoms as well as chronic symptoms. Altered microbiota. So we all have normal gut flora, in our GI tract, and so disrupting that, can, whether it's from an infection or harsh antibiotic or processed food or things like that, that can also can trigger and cause IBS. And then what can make the symptoms worse? Like what's going to be something to try to avoid or try to figure out what could be causing the worsening of the symptoms. So like I mentioned, prior gastroenteritis or stomach bug, certain food intolerances like lactose intolerance, gluten sensitivities, things we'll talk about a little bit later. Chronic stress is a big one. And then surgery, that's different type of stress to the body, but this can all make symptoms worse. And so when should you worry? So this is what it's always going through our head when we're evaluating new patients or patients we suspect who have IBS. Do they have any alarm symptoms? So what does that mean? Alarm symptoms are like symptoms where you're concerned about something that needs to be taken care of right away. There's a risk of worsening if something's not done, whether it's treatment or more diagnostic testing, things like that. So big alarm symptoms include weight loss, malnutrition. So weight loss that tells me that either you're not absorbing your vitamins, minerals, nutrients due to inflammation or some other reason, and so that's concerning. Bloody diarrhea. So that could be benign from constipation, or from a GI, like a GI bug, that gets better after a couple of days, or it could be from chronic inflammatory bowel disease. But that's concerning because that can signify chronic inflammation. And then obviously, also if there's a family history of chronic illnesses, specifically autoimmune disorders. So family history of inflammatory bowel disease, celiac disease, or our other autoimmune disorders in first-degree relatives can increase the risk of developing that, a similar autoimmune disorder, or GI condition in other family members. Things we're always looking out for. And so moving on to treatment. So this is one we're going to spend a little bit more time on, and I want to give you guys enough time for questions at the end. But treatment is it varies per patient. I have so many patients that are treated with so many different types of medicines or modalities, diet, and so there's lifestyle modifications. We'll talk about that a little bit. There's diet options, which can be very helpful, but challenging. Any diet is, anyone who's been on or has tried a diet for a significant period of time can tell you how hard it is. It's a big lifestyle change. We have medications. We have wonderful medications, but they're not perfect. They treat the symptoms. They treat the diarrhea. They treat the constipation, but we don't have a lot of medications that treat that underlying visceral hypersensitivity or hyperalgesia. And then there's also psychological behavioral therapy, which can be very helpful. The challenge there is finding a provider, that does this. I think it's a challenge everywhere, but a little bit more challenging in less urban, more rural settings. And then one of the newer therapies called IBS-STIM, which we'll talk about a little bit. So lifestyle modification. So sometimes it's just improving some things in your day-to-day life, whether it's exercising more or stress reduction. Again, that's easier said than done, because some of these stressors in kids are not optional. Maybe stressors at school or stressors at home, and many times these children don't know what stressors they are. That's usually the case. It's an unidentifiable stressor, so it can be really challenging to treat. But other things that, like, improving sleep hygiene. So these are all kind of other types of stressors to the body. So anything that throws your body out of its equilibrium. So sleep deprivation, prolonged fasting can also cause worsening symptoms. And just making sure that you're staying hydrated and eating healthy and exercising and trying to turn that tablet off or that cell phone off within before 2 hours, at least 2 hours before bedtime, which is really hard now because everything's on a tablet or on a cell phone. Everything's electronic, so it's really hard to do that. And then talking a little bit about diet. So there's a couple diets that can be helpful. So gluten restriction can sometimes be helpful. A lot of the pediatricians, before they refer some patients to us, or oftentimes will even recommend a 1 or 2 week trial of a gluten-free diet. And we don't see the patients or a lot of the patients that respond to a gluten-free diet. They do a gluten-limited or gluten-free diet, and they're better, and then they don't need a CGI. And we're not sure why this is helpful, but and it's unclear if this subset of patients that respond to gluten restriction have some degree of what they call non-celiac gluten sensitivity, which is basically gluten sensitivity that's not related to celiac disease. And then there's also something called a low FODMAP diet. Again, these diets can be challenging. It's not something you just say, okay, I'm just going to change my diet easy, because it has to be a whole household effort. Who's buying the groceries? So if I'm talking to families and I'm talking to a parent or guardian, and the other parent or guardian goes shopping and we're talking about diet, it may not be as helpful unless the other parent or guardian's there that actually does the shopping to talk about some of the benefits of some of these diet restrictions trials. And so the low FODMAP diet. So what does FODMAP stand for? So it's fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So it's a big mouthful. But there's a lot of great data that shows that this can help reduce stomach discomfort, pain, bloating, improve quality of life of patients with irritable bowel syndrome. And adults have more control over this diet, so adults with IBS, but kids have less control. So when we recommend the low FODMAP diet, the dietitians in our office, they'll talk about like a modified low FODMAP diet, which is a little bit more realistic to adhere to, because adherence is tricky. It's tough in kids. So here's an example of some options. So like foods that are high FODMAP foods that can sometimes worsen symptoms that you might want to limit or avoid. So like certain vegetables like artichoke, asparagus, cauliflower, garlic, green peas, things like that. Fruits like apples, apple juice, cherries, dried fruit, mangoes, nectarines, and dairy alternatives. So cow's milk, custard, evaporated milk, ice cream, things like that. And other protein sources like legumes, some marinated meats, poultry, seafood. And then certain breads like wheat, rye, barley-based breads, breakfast cereals, and some sweets, sugars, high fructose corn syrup's a big one, and cashews and pistachios. And so some alternatives. So for vegetables, doing like bok choy, bell pepper, carrots, cucumber, things like that. Fruits, trying replacing some of these apples, cherries with cantaloupe, kiwi fruit, mandarin, oranges, pineapples, things like that. And instead of cow's milk, try almond milk. We've had some patients that have tried that and responded well. Feta cheese, hard cheeses, soy milk, things like that. Made from soy protein as opposed to whole soy. And so that's the big difference between them. And then instead of like some marinated meats, poultry, seafood, you can do tofu or eggs and things like that. And then with the grains, gluten-free cornflakes, oats, quinoa flakes, things like that. Dark chocolate can be a nice alternative to some of these sweets with high fructose corn syrup. And also, like nuts and seeds, like doing peanuts, pumpkin seeds, walnuts, things like that. All right. And then getting into medications, we do prescribe a lot of medications. Some work, some don't. And so for patients who have IBS C, constipation, abdominal pain with constipation, some of the common laxatives we'll use is polyethylene glycol, which is Miralax or Gavalax, depending on what you see in the stores. That's an osmotic laxative. So basically that means it keeps water in the large intestines. And so I kind of just refer to it as a stool softener, because that's essentially what it is. It keeps water in the large intestine, mixes with the hard stool, and makes it easier to pass. But it doesn't push out any stool, so it'll increase the sensitivity that you do have to go, but it's not going to force you to. But some of these other ones like Senna and bisacodyl, so Senna is like chocolate extracts, bisacodyl, Dopalax, those are stimulant laxatives, so that will actually increase the motility of the intestinal muscle and squeeze some of that poop out. So we'll actually use both of those combination occasionally for doing like a prenup, for example. And then antispasmodics. These ones we primarily use in diarrhea predominant or IBS-U, where they don't have constipation or diarrhea. And these antispasmodics will basically, typically after you eat or drink, eat a large snack or meal, 30 minutes after you have what they call as gastrocolic reflux. So basically your stomach sends a signal to your large intestine, basically telling it to spasm to get rid of old poop, poop that's already there, so it makes room for new poop. So the body's really smart way of making sure things are working. The pipes are working, everything's moving along. And and sometimes that spasm can be really uncomfortable and painful, and it causes some patients IBS symptoms. And so hyoscine is one that we use that is, it's a nice option because you can use it as needed. You can use it 3 or 4 times a day. It just melts on the tongue. You don't swallow it. And then there's also one we use anywhere from 2 to 4 times a day called dicyclomine, and that's more on a standing basis. And I've used both of these, and I've had some patients respond to one and not the other, and so these can be helpful. Peppermint oil is actually pretty interesting, and it's, there's some data to show that it can act on intestinal muscle, like smooth muscles, and basically can reduce intestinal contractions, which is very interesting. And basically, there was one study that showed after 2 weeks of peppermint oil, 75% of the children receiving peppermint oil basically reported less pain intensity. So the severity of the pain was less compared to the placebo group, the patients who weren't getting peppermint oil. But it's not, it's not FDA approved, and so, but it's something you sometimes you might hear us talk about or suggest. And then there's the antidepressants. So this is also important. It's not our first line, but medicines like amitriptyline, which is technically called an antidepressant, but they actually don't use it for depression anymore. And citalopram, which they do, but we use more of amitriptyline versus citalopram. And there's a lot of good studies showing how helpful these medicines are, but it can take a while. It's not going to be an overnight fix. So I tell families that start amitriptyline specifically that it can take several weeks. And one study in kids age 12 to 18 who had new onset irritable bowel syndrome, they basically showed that they had the amitriptyline led to an improvement in their quality of life 6, 10, and even up to 13 weeks after starting it, which and also improvement in belly pain, which is really which is awesome. It's really good results. And then citalopram, there was a small study that showed there were 21 patients between 7 and 18 years of age with recurrent belly pain. Most of them, about 85%, basically said there's some improvement in belly pain, in addition to some other symptoms like anxiety, depression, and things like that. So those are all great tools in our toolkit. And then probiotics, there's initially we had some high hopes for them, and we'll go into them in a little bit. They're generally speaking something we may suggest overall. They're not the magic solution by any means, but there's been a couple of reviews lately. This is just looked at. I think this came out in the last couple of years. They looked at a bunch of different studies in kids and probiotics, and basically there's just not a lot of evidence. We don't have a lot of evidence that shows how effective they can be, because there's a lot of these kids responded to probiotics, but then a lot of the kids responded to placebo, which is like the sugar pill. But what's most important is that these are safe. So if it's something that you want to try, it's by no means, it's something you can absolutely try. And if it helps, that's great. That's awesome. And there's another study, I think, that came out maybe like a year or two before, but this one, I think it was in Europe, but they looked at 2 different or 2 specific types of probiotics or specific types of lactobacillus. And they saw that one of them, called Lactobacillus reuteri, did appear to have show some decrease in the severity and intensity of pain in kids with IBS and other types of functional pain. So it's just that there's not a lot of controlled studies in probiotics in kids, so the evidence is low, but the general summary is that they are safe, and if they work for you, then I would continue taking them. Then also there's psychological and behavioral therapy. So again, this can be challenging because we don't in the surrounding Springfield area. There's definitely a need for psychologists, psychiatrists, counselors. So I have a few patients that see a specialist or psychologist and get some behavioral therapy. Cognitive behavioral therapy, and I'm not a psychologist or psychiatrist, but helps kind of change the way you think about, your symptoms and things like that, which can be helpful. Hypnotherapy has been shown to be to help some patients with IBS, and also yoga therapy. So, and what this really gets to is that trying to distract the brain essentially from being focused on this on the spasming of some of the GI symptoms, which can be helpful. And then this is pretty cool. It came, I mean, it's not so new anymore, but this is called IBS STEM, and it's something that we're not set up to do at Baystate yet. We've been trying for a little while, but basically this is a type of neurostimulation. So it's called percutaneous electrical nerve field stimulation. That's the generic term for it. But I don't know any other company has an IV stem that has it in the market. But it was FDA approved. I think it was in 2019, sometime early summer. But the issue has been getting insurance to come along and approve this. But basically, what this is, it's a small single-use electric nerve stimulator that is placed behind the patient's ear. It has this battery-powered chip that emits this like low-frequency electrical pulse or pulses to stimulate branches of these certain cranial nerves that run through here. And then it does that continuously for about, I think, 5 days, and then they get replaced. And then, the theory is that stimulating these nerve bundles in and around the ear thought to provide pain relief. This can be used for up to 3 consecutive weeks to reduce functional abdominal pain associated with irritable bowel syndrome. And I've had some colleagues at other larger institutions that have actually tried this, and they were like blown away with some of their more complicated IBS patients that didn't respond to anything. A couple of them responded really well to this. Again, it's an issue of insurance coverage, but the preliminary data looks really promising. Let's see. Okay. So this is kind of a generalized therapeutic approach in treating patients with IBS. So I like to kind of have this in like a little kind of flow chart here. So basically, when we see a patient, we treat their IBS, but then how do we do that? So dietary changes is an option, but it's really tough because again, adherence at any age, particularly kids, is really hard, especially if the entire family's not on board. And then making sure address and treat psychosocial dysfunction, which typically the pediatrician has already kind of tried to do before they see us. And then usually, if that's ineffective, we try to determine, okay, is this IBS, it's constipation predominant or diarrhea predominant? Usually, we'll be able to fit patients in those 2 big buckets. Not always, but most of the time. And so, if it's constipation predominant, like I said, we do laxatives can be really helpful. One other drug that I think I forgot to mention that just got FDA approved in kids 6 to 17 is something called linaclotide. It's actually a pill form that if patients are having a constipation, they're not responding to laxative, that's another option. But again, the biggest issue is insurance coverage. Probiotics, again, we've been trying that, but again, variable success depending on the patient. Cognitive behavioral therapy, if you have the resources in the area or providers that perform that therapy. And then pharmacotherapy, so like medications with regards to the constipation. And maybe using like prokinetics, like the stimulant activity. And then, if it's the diarrhea type on the other side. And so I don't agree with the low FODMAP you can do on either side. But this flow chart has it just in the diarrhea side. But it's I've used recommended on patients with constipation, predominant IBS, and who have done well. So again, probiotics can be tried. Antibiotics is something that we didn't talk about, and something I don't typically do, but one specific condition that we may treat with antibiotics is something called small intestinal bacterial overgrowth, which is not super common in otherwise healthy kids. If they have some sort of underlying diabetes or motility disorder or something like that, there are increased risk for small intestinal bacterial overgrowth, which will respond to antibiotics, but this is not something common. But antidiarrheals we'll use, like Imodium, things like that. There's things I didn't talk about, like bile acid binders, like something called cholestyramine. I don't use that a whole lot in IBS, but some of my colleagues around the country sometimes use it. Antispasmodics, the hyoscyamin, the dicyclidine, and then cognitive behavioral therapy or other psychological, approaches. And then, you try one, that doesn't work, you try another one, and then you move on to more novel therapies, the pain moderation. I've had a few patients that I've talked about that IBS sim, but we just haven't been able to get that set up, which is unfortunate. So we're still working on here at Baystate, and so stay tuned for that. And yeah, and so summary. IBS is very common. We see it all the time in the clinic. It's not just common, in the general population, but also, obviously, it's a lot of our patient population. Testing is not absolutely necessary in making the diagnosis, but sometimes it's needed to rule out other diagnoses. And every person's IBS is different. So there's constipation or diarrhea or certain stressors. So it requires different approaches. And the biggest takeaway is managing stressors can make a huge impact on symptoms. So I have some patients who, they may not be fully aware, but it's just making these minor changes or meeting with, psychiatrists or psychologists, once or twice just to see how it goes. And I've had patients that have been like blown away at how helpful they've been. So, but again, the issue is finding those providers in the area. So ready for questions. This is me a couple of years ago, dressed up as someone sitting on a toilet. I don't know if you can see it, so I thought it was appropriate.
It's awesome. I love your family too. Oh man, that is so sweet. Great costume. Did you make that yourself?
No, I'm not that talented. I got it. The reason I really got it was because there was a fan in it, and I always run hot, so I was like, perfect.
Very good. Great. Well, great picture, great presentation, and we do have a number of questions for you. If you don't mind, we could just launch right into that. Let's see. So the first question, can you have IBD and IBS at the same time?
Yeah, you can hear me? Yes, I'm good. Absolutely. And so that's a really great question, because I think the old teaching was that irritable bowel syndrome or IBS is a diagnosis of exclusion. And I've heard that from some learners that whether it's, past several years with some medical students and residents. And I always make sure to let them know that, no, this is something that can coexist. Absolutely. And so when I talk to families about, let's say they have inflammatory bowel disease, and I talk to them also having IBS, I would say it's actually uncommon for the IBD to not affect your day-to-day activities and day-to-day life. So I'm surprised more folks with IBD and chronic conditions don't have IBS, but absolutely they can coexist.
Very good, thank you. Can you repeat what the FODMAP, the FODMAP stands for again?
Yeah, it's a mouthful, but it's fermentable oligosaccharides disaccharides, monosaccharides, and polyols.
Very good. Thank you.
Yeah.
So, introducing FODMAP, is there a food group that you recommend starting with, and should patient work with a nutritionist?
So to answer the last question, absolutely. So whenever I recommend a low FODMAP diet, we always have, or try to set up an appointment with our dietitian. I did at my prior institution, I've had limited nutrition support, so I would sometimes be like part-time nutritionist. And so there's actually some websites out there that can be helpful. There's something called monashfodmap.org. Is it .com? I have to look. That's where one of the that FODMAP chart came from. And so if you type in Monash, MONASH FODMAP, it comes up. But they actually have an app, but I think it costs like $8, where it has everything there, and then the website has a lot of the resources. So what I'll oftentimes do is tell families, like, check out this website, just kind of take a quick look at it while you're waiting for the nutrition appointment, because we want them to start some of the dietary changes immediately, but the nutritionist kind of going into really detail about what specific foods that they would like, or preferences based on whether they're picky or not, and it's more individualized, which is why nutrition can be very, very helpful with that.
Sure. I mean, anybody who's ever had to feed a child knows some of those challenges, right?
Absolutely.
The next question, and you covered this in your talk, but maybe you want to address this. How important is probiotics in IBS?
I think it says prebiotics. So
I'm sorry. You're right. Prebiotics. My bad.
Yeah, we've had these. I've had this brought up a couple times. Like, is prebiotic better than probiotic? And again, they're kind of all lumped together. So one of those studies I talked about symbiotics, which is basically a mixture of all of them, the prebiotics and probiotics. And it did show that generally they may be helpful, but again, we have limited data. We just don't have great, controlled studies that and reliable reporting, because a lot of it's reported. It's not something measurable, like objective. Like, we can't check a blood test or a stool test and be like, oh, your IBS is better because of this probiotic. So it's all reported. So there's something called recall bias. So and if someone's really interested in a probiotic and they're gonna really be encouraged or motivated for that to work. So they're like, oh, I think it helped. So it's really hard to get an objective answer on reported symptoms. So the general answer is there's not a huge difference as of right now between prebiotics and probiotics.
Very good. Thank you. The next couple of questions kind of cover this, but I'll read the long one. Is it possible to have frequent IBS symptoms as a young child, and then it improves, not requiring medication, and then in teen years start having symptoms again?
Yeah, that's possible. And the other possibility is that, was it IBS to begin with? I'm assuming that it was, but it's very possible that it could have been something else. There's a general term called functional abdominal pain, and there's no real age cutoff with IBS, but typically IBS is more common when you get to adolescent, teenage years, and usually younger than that, it's more functional abdominal pain, but it's kind of like a spectrum because treatment approaches are very similar. But yeah, and a lot of that has to do with, the growing body, the changing in the hormones, the stress levels, and absolutely that can kind of be in remission, so to speak. And then depending on certain environmental exposures and things like that can flare back up.
And then so to the next question, can IBS be outgrown then?
Yes, and it's, this is a caveat because we only see kids. So we see them until 18, 20, 22. and then they kind of move on to adult specialists. But a lot of it's kind of like, you're when you're an adult, you start, you managing the symptoms better. You're better about managing your own health. I think, we were all teenagers once. We probably didn't manage our health the best way we would have if we were like 30 or 40. So being adult and being a little bit more in tune with our own bodies can be helpful. And then managing the stress, because we all have certain levels of stress, and managing them in a healthy way.
Thank you. The next question is the peppermint oil an essential oil that is used?
It's a good question. I'm assuming so. I'm not sure if there's a difference between essential peppermint oil and other types of peppermint oil, but that's the one that I've seen used.
Very good. Can you explain how IV stem works again? There was some noise interference.
Oh yeah, so it's basically there's this like little nerve stimulator on the back of the ear, and then it just sends these electrical impulses for, I think continuously for a few days, I think 3 to 5 days, and I think the sessions are usually a few weeks, and it's this nerve stimulation has been shown to help limit and even resolve some of these patients with refractory IBS symptoms. We've tried kind of everything on that list. But again, it's limited because insurance is still not covering, a lot of insurances aren't covering it. So it's the population that uses it is limited. But yeah, yeah.
Yeah, it sounds fascinating. The next question, how long does diagnosis typically take? And then how often does it typically take to land on an effective treatment?
Is all IBS treatable? So, so that's some very good questions. Diagnosis can be day one. I saw someone today, and I was like, I am as certain as I can be in this time frame that you have IBS. I've had a few patients that I was convinced with IBS, and for whatever reason, we did additional testing, and they didn't, and that's why we do the test. And so, if I was more confident, then I wouldn't have done the test. So that's the reason why we do some of these testing. So it varies. So it can take the first visit with us, or it could take a few batteries of tests, like if you had an infection and the infection had begun to clear out, and then you're still having these residual symptoms, and making sure it's not inflammatory bowel disease. And so it varies. And so the second question is going to land on an effective treatment. Again, I hate to be repetitive, but it just varies. I have some patients that started medicine, they're just like, great, this is awesome. But honestly, that's probably less common. And so if, the patients that seem to respond the best are the ones that are seeing more other providers other than myself. So if they're seeing me, the dietitian, and then if they are seeing a counselor or psychiatrist all together, that's the best approach, a multidisciplinary approach. And in a perfect world, that would be wonderful with me and the dietitian and a psychologist or someone just went in the room together, and then one of us, after a visit or two, would peel back saying, okay, you need less of my services and more of nutrition, or vice versa. But unfortunately, that's more of a pipe dream. But it can vary. It can sometimes take several treatment options and tests before we kind of determine the best treatment. And all IBS is treatable. There's a caveat, because celiac disease, for example, before that was discovered, that was lumped in with IBS. So it's like, oh, I don't know, these IBS patients, they're just losing weight and not really don't like this gluten or whatever, the bread that they're eating. And so we don't know if there's, down the road, are we going to find this other diagnosis hidden in the IBS umbrella that could have some sort of diet therapy specifically, like celiac disease. It's hard to say, but for all intents and purposes, for the diagnosis of IBS, yes, it was all treatment.
Excellent. So there was a compliment about your costume, and they said it was great. This person's son has Crohn's and IBS.
Yeah, I have a lot. I have probably at least a dozen or so with the same diagnosis. And sometimes it can be challenging, especially in the first, not to get into inflammatory bowel disease, but some of these patients, when they go through their first winter and GI bugs, they're not immune to the GI bugs and food intolerances, because it can look just like how they presented initially. And that's where it gets challenging. So where we do an exam, check tests, and like, oh, well, it looks like everything else is in control. It looks like this could be infection or IBS, but that's not uncommon.
Oh, that's too bad. Are there instances of IBS in children on the is IBS in children on the rise?
Anecdotally, I don't think so. I don't know. This is probably more appropriate. Just looking at the data, there's nothing to suggest that's the case. However, given since the advent of the iPhone, there has been increase in anxiety and depression in our youth population, and that's multifactorial. It has a whole host of things with social media and things like that, and there's a connection with anxiety and depression with IBS, and so I started treating IBS in mid 2010, so I think that was 10 years after the iPhone. So for me, I haven't noticed an uptick, but I wouldn't be surprised if I look back and somewhere around the mid 2000s or 2000s, that it could have been a tick after that.
So the next question, is there a recommended food group to start the low FODMAP diet?
Not necessarily, but what I usually tell families, and again, I'm sure if Nancy, our dietitian, were here, she would jump right in and be all over this. But if there's one of those food groups where you just eat a ton of it, whether it's the grains or the fruits or whatnot, that would be one where I would start, because that has the highest yield of change from switching from certain grains to gluten free or some of the cheeses or things like that. So looking at that chart, you can say, okay, I eat way more in this group. Whichever ones you eat the most of, would start with that one. It in the long run, starting anywhere is reasonable.
So we're rounding up to the last question. Just want to make a point that if you have any questions, you can type them in the Q&A. And I'm going to paraphrase this last one. This person's son has the Crohn's and IBS, and they're wondering if the thiamine will help his stomach pain after eating.
That's a tough one, because I don't know enough about the Crohn's disease, because stomach pain after he eats. It's possible that, assuming that the Crohn's disease is under control and good levels and everything, and stool tests are normal, blood tests are normal, that I sometimes, and you said he has IBS-C, so that's not uncommon. Some kids with Crohn's disease will develop IBS-C or constipation. Hyoscyamine can sometimes help, but honestly, sometimes starting like a Miralax, like a laxative, or even a little bowel flush can be considered, and see how he does after that. And if it's on the fence, you're like, well, I don't know if he's really constipated, he's pooping every day, but his doctor or someone says he has constipation. An X-ray can sometimes be helpful too, to see if there's a large stool burden. So either one of those options would be reasonable.
Right. Very good. Thank you. And to reach out to their pediatric gastroenterologist.
Right.
We are at the end. There's a number of thank yous, Dr. Menz, for your presentation and for the Q&A. So we thank you all for attending, and more thank yous. This person says it's great, super informative. So thank you for your time, Dr. Menz. I know you're seeing patients all day and making time for this. So we thank you very much.
Happy to do it. Thanks everyone for coming. Hope you took a couple of the points and able to apply them to wherever in your life may or may not have ideas.
Excellent. Thank you.